I would like to introduce Dr. Daniel Lee. Dr. Daniel Lee is the director of the clinical chemistry at the University of Minnesota Medical Center. She is also an assistant professor of laboratory medicine and pathology at the University of Minnesota, Twin Cities. Dr. Lee earned her Bachelor of Science in Chemistry from Zhejiang University in Hangzhou, China in 2002. She also got a PhD in analytical chemistry at the University of Minnesota in 2007. She completed the clinical chemistry fellowship training at the Johns Hopkins University in 2009 and joined the faculty at the Johns Hopkins University in 2010. Dr. Lee's research interests focus on development of plasma biomarkers for Alzheimer's disease and cognitive function. She is the recipient of the 2015 New Investigator Research Grant at the Alzheimer's Association. As a clinical director of the clinical chemistry, she also oversees point of care, so I work closer to her. And this is what brought us together to work finding some answers to these issues that we were finding. And she's going to talk about the results of the comparison of point of care and central laboratory methods for the measurement of cardiac troponin. Dr. Lee, please.
Well, good morning. Well, Pedro, thank you for the nice introduction, and thank you, the North Country Point of Care Network, to invite me for the talk. I'm delighted to be here this morning to really share with you investigation that we performed here to help our ED doctors to understand the discrepant results between a point of care test and a central lab test. So let me start. Okay. So this was a case that brought to our attention around September last year. So an ED doctor calls and questions about the discrepant troponin results between the central lab test, which is Siemens Vista Dimension, and the point of care device, which is Abbott's iStat point of care. So the story was that the lab actually started to use the Siemens Vista Dementia Analyzer to perform the troponin test on July 30th, 2014. So, and then since that, they have seen more discrepancy. And so the discrepant result really was concerning to them, because that they don't know what to do with the patient who may have a positive by one test but negative by the other. So maybe before I get into the concerns that they have, I should tell you that how our ED doctors are using the iStat troponin test. So in our ED, which is actually located here at the Masonic Children's Hospital, the way that we use it, the iStat troponin test, is that the nurse would use it for screening. And then 90% of the time that actually nurses would order the test, and then they would, if the test is positive, then they would move the patient to the observation unit in cardiology. And then also they would use the iStat or the central lab method to do serial testing of patient to follow the results. So they have two different way of using it. When the discrepant happen, as you can imagine, then it would cause confusion for the nurses or the doctor to know that whether they should move the patient to the observation unit or not. So that's why that that's why there's a lot of concern there. And then some nurses would actually refuse to order the iStat because they don't think it's accurate. And that's their words. And then, so because of this, that ED decided that they should actually order both tests when they use for triaging their patients. So they would do iStat point of care as well as send a blood sample to the central lab, and then so that they can get both information. But as you can see that this can still be confusing, right? And then also that at that point, they chose to only use the VISTA test for serial testing, not the iStat troponin. So that was how the scenario that's happening in our ED. So in summary, that the ED physicians and nurses were really concerned. And their question was that, so what to do with, is there really a discordance between the point of care test and the central lab method? And then they, as I said, that they started to ordering troponin for triaging patient using both methods. So when they called me and then also talked to us about their concern, we actually meet with them and then understand that they have been ordering both tests on patients. So we decided that we should look into this problem. So the aim of our investigation was really to determine whether there's a difference in the diagnostic ability of the point of care method and the central lab method for screening acute myocardial infarction in the patient with suspected acute myocardial infarction. I wanted to emphasize screening, this word, because as you all know, that's not the intended use for either point of care test or the central lab test for testing troponin in the setting of diagnosis of myocardial infarction. However, that in many EDs, that including here, that ED doctors do use the test for screening purpose because it works. Their workflow is such that they want to triaging patient, get them out of ED fast. If they don't have a myocardial infarction, or if they do, they want to move them into the observation unit in cardiology so that those patients can be best taken care of. So that's why that even though those methods were not recommended for screening, in some settings that doctors use it that way. So we decided that we perform this study, and here is how this study was organized. So the patient that we target is the ED population here at the Masonic Children's Hospital. And also specifically, the patient were suspected to have acute myocardial infarction. And as I said before, that ED doctors decided to perform simultaneous testing of troponin on those patients and using both the iStat point of care test as well as the central lab Siemens dementia test. And then what we did was that we retrospectively looked into 3 months worth of data that we have, and then to determine both the sensitivity and the specificity of those two tests at the screening situation. So just give you some, the cutoff that we currently use here for screening acute myocardial infarction. So for ISTAT point of care test, we use the cutoff of 0.11 microgram per liter. And then, so this cutoff is slightly different from what's being recommended by Abbott. Well, the reason is because when we first implemented the ISTAT point of care in our ED several years ago, that we looked into literature, and then we found a study that evaluated imprecision of ISTAT point of care, and then we decided that this cutoff 0.11 microgram liter was more suited for this purpose than 0.09 microgram per liter that was recommended by the manufacturer. So that's why this cutoff is slightly than probably what you are using at your institution. And for Siemens Vista method, we use what's recommended by manufacturer, 0.045 microgram per liter as the cutoff. So any test results above those cutoff were positive, and then ED doctors would then triaging the patient to the observation unit based on those results. So this is what our study demographics. So we had actually 254 patients who had simultaneous testing of a troponin by both methods. And 53% of them were male, and 47% of them were female. And then also, as you can see, we have a pretty diverse population, and then 72% of them European Caucasian, 11% of them are African American, and then 6% are African, and then 3% are Asian. So we are population, although this is reflecting our population, I think that other studies may have a slightly different demographics than what we have here. So here is what we found in terms of sensitivity comparison between the ISTAT point of care and Siemens Vista. So among the 254 patients who were suspected to have acute myocardial infarction, there were actually 15 cases of acute myocardial infarction. And 10 of them were positive by the ISTAT point of care. And 13 of them were positive by Siemens Vista. So, what do you think? Is this something expected based on your understanding of the point of care test and versus the central lab test? What do you think, Pedro?
Well, I think because of the different setup will probably influence, and also I believe that Siemens has more sensitivity to the point.
Okay, so Pedro mentioned two things. One is the cutoffs, and then second is that inherently whether there's a difference in terms of sensitivity between those two assays, right? Well, I think that he had really two good points. So let's say, but when we're just looking at the data itself, and then we say, all right, well, it seems like the Siemens method is more sensitive than the ISTAT, right? Well, because by Siemens method that there are 3 more were positive, and even though both methods that missed 2 patients. Why is that? Chris? Okay. Yeah, could be. So could be something interfere with our both method.
It could be the patient came in before that 4-hour window. I mean, we got 4 hours before the time medicine, so depending on the speed they get to the ER, that's why the essence of screening, but if you have the
Yes. What's your name? Current? Yes, that's actually where those were the actually reasons for those 2 cases, because later by both methods that we saw the rise of troponin. So in those 2 cases that missed by both methods, it was because that both method, in other words, both methods were not sensitive to detecting it because patient was still way too early that in the pathophysiological process of acute myocardial infarction. So, all right, so we know that this data is telling us that Siemens Vista is more sensitive than ISTAT point of care for the screening purpose. But we may see a slightly different picture if there is different cutoff, although I can tell you that's not necessarily the case. All right, what about specificity? Well, looking at those 254 patients, actually 239 patients actually did not have acute myocardial infarction. But 11 of those 239 cases were declared to be positive by the ISTAT point of care. And 29 of them were declared to be positive by Siemens Vista. So, what do you think about the results? Yes?
Well, your sensitivity for the Siemens is probably set too low, and there were false positives because of that.
Yes, I like you said false positives, right? So those 29 minus 11, 18. Well, those 18 more false positive by Siemens Vista, and could be that the cutoff is too low. But if we raise the cutoff, yeah.
I think that we just have to be careful that we say that they're not false positives. They are true positive. Generally, unless it's an analytical issue, it's a positive result, but it's actually predictive of risk. And so I think you have to be careful on how you differentiate that. And I would also just ask if maybe you could clarify that if there was a difference between STEMI and non-STEMI patients.
Okay, so first this is Dr. Amy Singer, and she's actually our medical director here as well, and she's an expert in cardiac troponin. So I really like her comment because she mentioned about, we have to be really careful about false positive, because just like Dr. Grenache mentioned that in his presentation that, we, in our lab, we measure biomarker. In this case, we measure troponin, right? But troponin can be elevated in many disease situations other than acute myocardial infarction. Just like in his talk that he mentioned that HCG can be elevated in many disease situations other than pregnancy, right? So those are not necessarily false positive. We did have those troponin molecule that present in those blood, but it may not be indicating of acute myocardial infarction. So to answer her question of STEMI and non-STEMI, so our pathology resident, when he looked into this data, and that it's actually the diagnosis of acute MI were specifically for both STEMI and non-STEMI. So, all right. So from this data, we can say that using the existing cutoffs that we have, that ISTAT point of care is more specific than Siemens Vista. So what would happen if we were say, all right, we want to raise the cutoff of Siemens Vista. We will maybe do our, we will not follow the recommendation of the manufacturer of 0.045. We'll raise the cutoff. What would happen? What would impact the sensitivity as well as specificity?
You could miss some MIs, so
Okay.
you probably wouldn't want it.
Okay. Any different opinions? All right. So, a different way of looking at the performance characteristics of both methods is by doing this called ROC curve. So the way that we look at this figure and to trying to get an understanding about the performance in terms of both sensitivity and specificity of those two methods is to look at the area under the curve. So the area under the curve, which is AUC, for ISTAT is 0.891. For Vista is 0.944. Well, it looks like Vista is better overall, right? Well, be really careful when you look at this figure. One question that I would ask is that, are those numbers statistically significant? That's one question. And in this case, they're not. And then another question is that, well, it really depends on the cutoffs, right? Because the way of using ROC, evaluating the comprehensive performance of both tests, taking into consideration of various cutoffs that you use for different methods. So it's really an overall performance, but when it comes to the specific tests that you do in your lab, like many of you have already mentioned, it is important to understand the cutoff. Because if you raise the cutoff in the example of Vista, you would actually decrease the sensitivity of the test, and then but at the same time, you can increase the specificity of the test. But the question was raised is, do you really want to do that in this specific situation? And the answer may be not. So what about the misses? Okay, so this table that actually summarized our results in a very nice way. So both methods that were negative for two instances of acute myocardial infarction. And then the point of care method missed 3 instances of acute myocardial infarction, and then the Vista caught those 3. So that's kind of the summary of our finding. So what do you think ED doctor would think about those results? Well, we actually met with them and presented to them our results. And actually, there's a variety of opinions, even among ED doctors, about what to do next. Well, I remember one doctor was very adamant that we should get rid of both tests. We should do high sensitive troponin tests because both tests miss 2. And we only had, well, it's a big study. We have 254 patients, but can you imagine, like, if you have tens of thousands of patients, how many are you going to miss? So that's one doctor's opinion, that we should do high sensitive. Well, I'm glad not all the ED doctors think that way, because many of them say, all right, this data is the results are very interesting. Well, we actually like the fact that Vista is more sensitive. But also we're concerned the fact that it gives us more false positives. Well, because those false positives means that they would move more patients to cardiology, right? Does cardiology understand they're getting all the false positive patients that move to their unit? And should ED doctor tell the cardiology doctors that about this? Well, I think that they are having this conversation. But in terms of what to do next, actually the consensus from them is that we should do both. Continue doing what we've been doing. So I see many of you want to say something.
It just seems awfully expensive for the patient.
Yeah. Yeah, Dr. Amy Singer?
I think it's important to say that really you're not, again, missing or diagnosing MI because the universal definition requires serial samples. So I don't think you can necessarily draw a conclusion.
Yeah.
And given the lack of standardization between the assays and not using the 99th percentile for the ISTAT, I would be against using the ISTAT in that setting unless there was a turnaround time issue, really. And I think in general, from all my conversations with ED physicians, they do want high sensitivity assays, so they want sensitivity. Cardiology does not want high sensitive assays because they don't want to have unnecessary rule, or they want to rule them in appropriately. But in the ED, they don't want to miss anyone, so it makes sense.
So I think that I want to address the turnaround time issue. It is much faster to have point-of-care tests performed on-site in ED. And currently, our turnaround time here for troponin, I believe that 80% of the time is less than 45 minutes. So that's current our turnaround time for troponin. So I told you that what is our ED doctor decided to do moving forward, and I heard a comment saying that this is going to be very expensive. Well, can you elaborate a little bit more why you think it's very expensive? Are you thinking about it's very expensive because you do additional tests that which probably in many situations is not necessary? Or are you thinking about from an overall perspective and how it really impact patient care? Can you elaborate a little bit more?
Well, in the whole scheme of things, if I'm having a heart attack, I want to make sure that in the whole scheme of things, I'm thinking that if I'm really truly having a heart attack, I want to know, and it's kind of scary to even think that both the Vista and the ISTAT missed 2. What if I was one of those 2? So I would be willing to pay more to have something a little bit more to get the AMIs and not to have not necessarily a false positive, because like the doctor was explaining that you would you know,
Yeah.
there could be other conditions besides that. So I don't know. Just food
Or
for thought.
I heard that you're kind of changing your opinion on that. Yeah. So, I don't think that it's I don't want to leave you, to have this impression that this is a straightforward answer to this type of question. It's really a complex answer. And I think that it's really, it's really, we have to really look at it from a big picture. And then, both how the ED doctor feel comfortable of using the test. And I think that in this case, we really helped them understand the limitations of both tests. Or I would say the good side about both tests. And the reason they wanted to have both tests results available to them is now equipped with this understanding of both tests, that I'm hoping that they can make better judgments based on the clinical situation of the patient. And I don't think that we should say there's one solution to every problem. But in this case, that even though they are doing the test, that they're using the test for screening as well as for serial testing, and then the screening part is not necessarily being recommended by any guideline, but it fit into the workflow of the ED. And I think that they're being really cautious about it. And so I think that this, I use this as an example to say that even we have to really investigate this type of situation, and then as a laboratorium, that we should really help the doctor to understand the limitation of the test, and then hopefully provide the information that they need to make the best clinical decisions. And hopefully at the end of the day, that those clinical decisions will help save costs in healthcare. Thank you. Yes. Final. Oh.
Is that
Yeah, I'm really glad you brought that question. All the things that I'm talking about here, it's based on one time point test results. Yes. Okay. Sorry, you have another.
I think what your study has shown us is that not only do we need to educate our EDs better, but we need to educate them in the fact that you can't use either a Vista or an iStat as a screening tool. It's not, as you said, the guidelines require serial testing for all of that. We need to educate them that we can't triage too fast if we're going to make these decisions. Serial testing is required no matter what test we use. So, and on the same methodology, we can't be going back and forth as well. So I think just reiterate that we do need to educate our doctors.
I'm glad you brought this up, because I hope that I don't leave you the impression that our ED doctors do not follow the patient using either test. They do. Okay, they do follow the patient. It's just that when the patient comes to their door for the first test, they do both, and then later they would use either test to follow those patients. Okay, so I'd like to acknowledge a few people. Pedro and I, he been working with me on this case, and then I think it's great that we finally were able to provide some health information to the doctors, and then also the two pathologists that they're the pathology resident who helped us is Dr. Victor Santiago and Dr. Miro Sikulik, and then also our medical doctor. Amy Carger, who was also involved in this case. And then also the ED doctors that who actually helped in this case, Dr. Eric Christensen and Dr. Gregory Lupnow, and then Dr. James Thompson. I'd be happy to answer questions if you have any.
I have one question since we participated in this, and I'm very glad that we did this. So my first impression when I got the EV calls regarding the discrepancy was, okay, so let's take a look at this. What is the cutoff? So then realize that they're different. So my first action was, so maybe we're having the wrong cutoff, knowing that it's different from the manufacturer's recommendation. And what is the literature says today about that? Are the other hospitals using this cutoff, or are there, also for all our point of care people here, so what are the cutoff used in the other hospitals for troponin? Are you using the recommended or different? 0.01.
Point.
0.01.
What method? Oh, 0.010? Oh, point 10. We use 0.11. Okay.
And what is your laboratory platform, the core laboratory? Oh, maybe. No, I mean the instrument that you use. The iStat? Okay. And the other one? Oh, Roche, okay.
Dr. Grenache?
What is the recommended cutoff from Abbott for
It's
troponin?
0.09, right, John? Oh, 0.08.
And so if you,
Okay.
But I think it's important that it's no longer recommended to use 10% wherever the 10% CV is. It's regardless of method.
Yeah.
It's to use the 99th percentile. That's what data supports. But that also requires serial testing.
Yeah. So do you all know the difference between 10% CV cutoff versus the 99th percentile cutoff? Well, Dr. Amy Singh, why not you help us to understand the difference?
The difference between the two? Well,
Yeah,
the
the difference too, and then why now there's a change from the 10% CV cutoff to the 99th percentile cutoff.
Sure. Well, the 99th percentile is basically just the number that's generated. If you had 100 people in a room and there was one abnormal, that determines what your cutoff is. And the 10% CV recommendation that was in the universal definition many years ago was basically just arbitrary, and it was driven to have manufacturers make more sensitive assays, knowing that if you have lower precision at if you have better precision at lower concentrations, that you'll be able to, do serial testing more accurately. And the 10% CV, there's data to show that you actually you pick up more MIs when you use the 99th percentile compared with the 10% CV.
Yeah.
So, there's literature out there. Happy to share.
Yeah, and then usually the 10% CV cutoff is actually higher than the 99th percentile. And that's why, as Dr. Singer mentioned, that using the 99th percentile, you can actually detect more. And this is really because that initially, when those troponin assay that came out, there's concern about the imprecision at the very low level. So that 10% CV is actually the concentration that those assay that can give you the precision about 10%. That's why it said 10% cutoff. But with the improvement of those assay, that then the manufacturer that can achieve better precision at those lower level, and therefore that they can actually lower the level now to the 99th percentile. And then so that's why there's a change of, from the recommendation from the 10% CV cutoff to the 99th percentile cutoff.
so I just want to follow up on my last question.
Sure.
if you had used the .08 cutoff in your single point comparisons, right? So I think it's clear that you didn't look at serial testing,
Yeah.
right, to put those patients into a bin. If you had used just for those single point determinations, the screening test, and using the .08 cutoff, what would the data look like then?
The conclusion is still the same. And then we actually looked at that. So there's one patient that if we lower the ISTAT point of care cutoff from 0.11 to 0.08, that patient will be positive on the first test. But there's still I believe two other patients that their initial level were still lower than 0.08.
And then last question for me, if your ED docs are going to continue using both the VISTA and the ISTAT, what does that look like? How do they integrate this workflow and these results into care?
Okay, so they have been using this, for a while. So they will continue. They basically will evaluating both results. But as you know, that the turnaround time for those two, methods are different. So they probably will get the ISTAT result first before they get the result from the central lab, right? So I think that they feel more comfortable of having both information available to them. Although I think that they would probably, depending on the clinical situation, using the first available test in combination with the clinical situation to decide that whether this patient should stay in ED or they should move to the observation unit in cardiology. And that's how they would use those results.
Any other questions?
Hi. Oh, wow. Do you order serial dilutions on every patient that you do a troponin on, or?
Are you talking about serial testing
serial? Yes, serial testing, not serial dilutions.
Yeah, they perform serial testing. That after the screening, they will follow those patients using serial testing.
And then how does the next serial testing, we do a 90-minute, how does that impact the decision that you made at the baseline?
That's a really good question. I think that, first of all, my understanding of their serial testing is that they will use only one test, either ISTAT or VISTA, to do serial testing and follow the patient that way. So I think that serial testing will really add a lot of information either to confirm the diagnosis or the action taken earlier, or will change their clinical decision making. And so I think that's how that serial testing information will come into play later.
Thank you. Thank you.
Yeah.
Is there any other questions?
There's one more.
I just wanted to briefly ask, when you guys implemented your iStats in your ER, what kind of training did you do and what kind of correlation study? Because it almost to me seems like it was just put into the ER and then they notice, everyone knows there's going to be discrepancies because it's a different method and the cutoffs are different.
I'll let Pedro to take first.
Yes, the training was provided, before implementing it, and that I believe the doctors also were involved in that. So, but the things changed when we implemented. We switched from the Vitros to the Siemens Vista, and that's when we started seeing those discrepancies. In my time in point of care, I never saw any discrepancy between the Vitros and the ISTAT. And they were doing the serial testing at that time, and it's instructed in the procedure. But since the results were coming out discrepant, they starting not using the ISTAT or doing it alternatively between the lab core analyzer and the iStat. As a result of our study, we recommended that they should keep going with the serial testing and following up with one instrument, not with both at the same time. So they're doing it now at the same time with iStat and Vista, but after that, they will follow up with any of those, whichever they trust best.
So I just want to add it to that. So this really, the discrepancy probably was present even before we moved from Vitros to Vista, but I was not here for the initial introduction of the point of care test to our ED, so I can't speak for that. But but I can offer a little bit my perspective. So I think that the reason why we've seen more discrepancy after we switched from Vitros to Vista in our central lab is because those two central lab methods that probably had, probably they used very different antibodies in their immunoassay designs, so that they would actually, so there's, even between those methods that there's some discrepancy there. And then in addition to that, there are different cutoffs applied to each method. So that whole transition, it's prompted this more prominent discrepancy between the iStat method versus the central lab method. And I would probably feel comfortable to say that even before we switched to Vista, there were some discrepancy, but not as prominent as after we switched.
Okay.
All right, thank you.
I want to thank Dr. Lee. Thank you very much for sharing your results.